Thank you. A warm welcome from International Diabetic Federation Southeast Asia region. I'm sure many of you must be knowing about the International Diabetic Federation, but those who don't know about International Diabetic Federation, it is a federation where countries member organization is member of this International Diabetic Federation. Probably one of the biggest international organization who is in one particular field of diabetes, but if I compare with obesity or cardiology and different other non-communicable disease, or even like folks in other countries, number of countries involved in this organization is 200. So we have one of the largest organization. Southeast Asia is one of the smallest region, but we have a lot of people with diabetes, and Southeast Asia region primarily having India. It's Indian subcontinent, I can say, because India, Bangladesh, Sri Lanka, Nepal, we have with us Maldives and Mauritius. Before some time, when idea of Southeast Asia region was created, at that time, even I think Indonesia and Thailand was also the part of it, but later on, it had become part of Western Pacific. Pakistan, even it is a Southeast Asian region, but because of political reason, it was given to Middle East. So it had become very small region, but very important reason, because one is that we have a lot of diabetic patients in our country and this region. But our challenge is that we are developing diabetes early in the age. We are getting diabetes in their 30s and 40s. So we get a lot of complication. India at present have second highest number of diabetes in the world, and we have highest number of cardiovascular disease, and it is not decreasing. Even we have so many education program which we are doing since last 25 years, 30 years, and so many newer molecules have come to treat and to prevent cardiovascular disease or even diabetes. Still, we are having increasing number of diabetes and increasing number of cardiovascular disease in our countries. With this, we have this reason originally started with International Diabetic Federation, but I can say that Professor Azad Khan and Dr. Anil Boraskar are founder for this reason. They are the one who are legends and living legends with us. So I'm really today very happy that we could invite both of them on a platform where they will be talking and we all will be learning from them. So learnings from living legends, the Professor Dr. Anil Boraskar and Professor Dr. A.K. Azad Khan from Bangladesh. And it will be shared with our close friend Dr. Shashank Joshi, who was immediate chair of IDF Southeast Asia, along with him, Dr. Dhania Vijaysurya. Husband Dr. Vijaysurya was also equally contributing person for this idea of Southeast Asia region. We know that because of that, we have also a Diabetes Asia was also started, and they have nurtured many of us, and we have become part of International Diabetic Federation because of their blessings by Dr. Boraskar sir and Dr. Azad Khan, and we all want to grow under their, Chhatra Chaya, under their blessings only, this Southeast Asia region. Being a IDF Southeast Asia region chair, I want to do a lot of activities. As we know that it is very fragmented. We were having less number of activities. We are doing some activities which become India specific. Then there are activities which may be Sri Lanka specific or maybe Bangladesh specific. I just want that every one of us, we can combinedly do a lot of activities. We may not be great researcher, we all are primary care physicians or primary care diabetologists. So we want to do more activities in this part of the world. The first thing what we have done last year when I was chair-elect, we have started IDF Southeast Asia Congress, and that was in Delhi, where we invited all of you and all those countries who are the part of IDF Southeast Asia. That meeting was for one day when Dr. Azad Khan was the chair for the International Diabetic Federation. That meeting attracted, it was along with RSSDA, so many delegates were there. This year we are doing a dedicated meeting of IDF Southeast Asia Congress, and we decided again the same month, November, we will be doing this meeting in Nepal. I'll be sharing more details of the Nepal program. Tomorrow is the IDF main body. They have their meeting, which is online meeting. I'll be listening. We will be discussing some aspect. Whatever we will be discussing in the IDF meeting, I want that we should also have immediately after that, there should be a Southeast Asia, all the members organization, we should have meeting. What we can plan for next 1 month to 2 months and the next 6 weeks or 3 months. That's my idea. So on 9th of June, same time, maybe around 8:30 to 9 o'clock, we will start meeting for 1 hour and we will try to understand what different activities which we can plan. We have 4 organizations from uh, Bangladesh, 2 organizations from Nepal, 2 organizations from now Sri Lanka. We have 1 from Maldives, 2 from Mauritius, and 3 from India. So I am inviting all their president-elect, secretary to join, and plus some of us who are very active member like Amit is now currently IDF Southeast, IDF uh, Diabetes School Chair, or Manoj or Makkar, and some of them were very active. We will be involving all of them. Wanted to understand what they can contribute, how we should go do the program for next 6 weeks or next 12 weeks. IDF is celebrating 75 years of its establishment. So I want that every one of us should be very active for this year, and we should celebrate 75 year of IDF establishment across the region, doing a lot of activities, and we have come out with the IDF newsletter. A newsletter which we have done last year, and again we will be releasing our newsletter maybe in month time. So whatever activities which you are doing in your region or in your country or in your organization, please share with us so we can release that newsletter and we can send it to the head office also. So with these plans, now I request for the first session, Dr. Shashank Joshi and Dr. Vijay, she joined? Madam joined, Dr. Vijay? Yeah.
She may
Okay,
not join. I'm not so sure. But
introduce.
Manika is there. Manika, madam is not joining, no?
Yeah, I
Manik.
think she had a
She had a
eye
she had
surgery
a
and
dental issue. So
yes,
she said she had sent her apology. So I would request Manika to co-chair with me if it is okay with you, sir.
Yeah, yes. He is always
Hmm?
there. He will be
I'm
Yeah.
there. I'm there.
vote of thanks also he will be doing. So now I request Dr. Shashank to introduce Professor Anil Boraskar, our patron, our senior advisor, our founder for IDF Southeast Asia, along with Dr. Ajad Khan. So first I will request Shashank to introduce Boraskar sir, and then we start with our first lecture. Thank you. And just to tell that around 1,500 doctors who have registered for this meeting, we have 1,300 plus 1,356 from India and around 149 from different parts of this region. But some of them have registered from China, Malaysia, even Far East, other countries along with Pakistan and even Middle East also. So we have good number of delegates who registered. I don't know how many of them have logged in now. But with this, I request Shashank to introduce Professor Boraskar.
So thank you so much, Bansi. First of all, I want to congratulate you and the entire board for this wonderful initiative. And we have with us living legends like Professor Anil Buraskar, Professor Azad Khan sir. So our pranam and namaskar to both of them. And it will be my pleasure. I'm also very happy to share this with our very close colleagues from Sri Lanka. Manika is here. Madam Dhanya could not join because she had a dental surgery. Of course, my brothers from India, Bansi, Manoj, Amit are all there. And Bishwajit has joined us. And many others, I'm sure, will join us. And of course, Professor Azad Khan is very much with us. So Professor Anil Boraskar is a teacher to me and Bansi both. He is the current honorary secretary of the scientific section of the Diabetic Association of India. He has been on the managing council of Diabetic Association India. He's a fellow of the Royal College of Physicians of London. He's ex-chairman of the IDF Southeast Asia. He has been a professor of medicine at the Grand Medical College and for more than 20 years, where he taught me. He's an honorary professor of diabetes at the All India Institute of Diabetes, and he has been editor of many journals. He's currently the editor of the Journal of Diabetic Association of India, and he's editor of the Boraskar's textbook of diabetes, which is coming up very soon. He's attached to SL Reja Hospital, Asian Heart Institute, as well as he has founded the Asian Cancer Institute. He has done cutting edge work in diet with Professor late Dr. B.S. Reja on dietary habits and remission programs 30, 40 years back when people never thought of remission. Then, of course, he transgressed and did a lot of work in heart disease and diabetes when he worked very closely at the Asian Heart Institute. And then his current passion was cancer and brain in diabetes. And he's a living legend. And we are fortunate and blessed to have a teacher like him. And he's an extraordinary human being par excellence and a born teacher. and he's going to tell us pearls of wisdom on art and science of medicine related to clinical diabetes, because he has been practicing diabetes for the last 45 years, and we have learned a lot from him. He's also very witty and jovial, so he knows how to blend laughter and humor in medicine. So that's something which is there. He's a scholar in Sanskrit. He's a scholar like Professor Azad Khan is also a scholar in Sanskrit and Bengali. So we have learned a lot of pearls of wisdom from both of them. And Professor Boraskar also has a passion in music and singing. Beyond just medicine, they are versatile personalities, and we are fortunate. And again, Bansi, I'm grateful to you that you chose it right to have this legend. And it is indeed my honor and pleasure and privilege to introduce Sir. So I'm honestly humbled. Thank you, Bansi and IDF Southeast Asia region, Manika and Dr. Azad Khan, sir, and everybody. And Professor Boraskar, the stage is all yours. I'm sure we are looking forward to your talk.
Thank you very much, Shashank, for your kind words. And I think you have gone overboard by giving me a lot of adjectives. And my wife, who is a strongest critic for me, she's sitting here and she's indicating to me that don't let it go to your head. So I'm really honored that you have chosen me to talk on a very important subject, and that is art and science in management of diabetes. You see, when you talk about art, and always you say this machine is a state of the art, a PET scan which has brought, or CAT scan which has come here, or a MRI, we say it's a state of the art. That means it always shows that the art is superior to science. Although foundation is based on scientific facts, data collection, but art is superior, and how to practice medicine in a form that it should look like an art is a matter of skill, and which I have learned from my great teachers, Dr. B.S. Raja, Dr. Rammurthy, and Dr. B.S. Singhal. They were my gurus and they gave me all this wisdom, and I'm really grateful to all my teachers. So can we have the first slide, please? Bansi,
Yes, sir. Wait.
kindly load that slides.
Sir, Nandkishore is doing.
Yeah, thank you. Now you realize that it is very important to first find out art and science in management of diabetes. Next slide, please. Art in management of diabetes, how it differs from science. Next slide, please. Physician factor leading to therapeutic inertia for insulin therapy. This is a primary cause of many complications, that doctors just don't put a patient on insulin at the right time. There are many problems with that. One is the prescription of insulin, resistance of the patient to initiate insulin. That may be due to knowledge barrier, cost and socioeconomic barrier, psychological barrier, low prioritization versus other disease, inability to manage, and lack of skills. There are so many factors. Basically, injection is shown as some kind of a weapon. As a child, we are told that if you behave in a naughty fashion, this doctor uncle will give you injection. So injection from childhood is ducked to our head is some kind of punishment. So this has to be first set aside before you tell the patient that, look here, what is going to really help you, and your HbA1c is 10, your fasting sugar is more than 200, your postprandial blood sugar is 300, we have to start you on insulin. All the skills, all the charm, all this thing, and there is one beautiful word in Marathi, unfortunately we can't translate it, patav, patwa patwi. You cannot patav a patient better than using a very sugary language and giving him the benefit of insulin. Next slide, please. Once the patient takes insulin, next slide, please. The perceived inadequacy, the perceived side effects, and perception of patient's attitude towards insulin and perception of patient with those barriers must be set aside. Next slide. How do you do that? That's really art. Next slide. The insulin conversation is very important. I always keep like busy doctors like Bansi, I tell them that on the day when you're relatively less busy, keep all the people that you want to put on insulin, because per patient you have to virtually spend 30 to 40 minutes. And he should get a feeling that, look here, this is my caretaker. He is telling me something good for me. And that's a really art of medicine. Timely conversation provides an opportunity to set a positive context for insulin therapy. This helps to prevent a sense of guilt or personal failure regarding insulin. A lot of people say, "Ki, doctor, you are starting insulin. Is it? My case is now at the last stage." Because I remember when my grandfather was given injection, within 2 months he died. I said, that is because your grandfather was started injection much later after he developed renal and cardiac complication. If he had started insulin early, probably your grandfather would be alive. Healthcare providers should focus on open-ended questions to identify the needs of patients, address the concerns regarding insulin therapy. Next slide. All the concern you should. What is the finite request? Request the patient to try insulin for a couple of weeks and then come back. And fantastic things that if you give the first shot injection yourself, the pain devices are very good and they're very friendly user. And the injections are nano needles with the 33 gauge needles. It does not even wake up a child in the sleep. It is bigger. It is smaller than the mosquito bite. So it's absolutely pain free. So request the patient to try insulin. Now he takes insulin for 2 weeks and he feels so good. There's a feel good factor. All the hyperglycemic malaise, dehydration, everything is reversed. And the patient feels, I'm feeling great. I was never so energetic earlier. But if he is not satisfied at the end of week, either he will not come back to you or he will stop taking injection. The first dose can be administered in the clinic. Positive changes that insulin brings about in 2 weeks may help them to overcome the patient resistance to insulin and develop a positive attitude to a long-term use. And people must get a positive attitude towards treating diabetes. Don't keep a gloomy picture. I see some of my colleagues, they keep the pictures of the patients with the amputation of toes, gangrene, all those frightening pictures, don't keep in front of the patient. You don't do proper control, you will have this problem. No, give a positive side of insulin. Next slide, please. Now, understanding concerns of the patient, multiple or complex regime. Now, this is very bad. Newly trained in a scientific institutions like our great institution of GS Medical College and all toppers, and they get 98% marks before getting admission. And those people are trained. So they give a complex regime to the patient. Now try to understand. You give a long-acting basal insulin in the morning, then an ultra-short-acting insulin before breakfast and after breakfast and before lunch and after lunch, and tightly control blood sugar by using CGMS between 100, 140, and we see what is known as time in range. And this active treatment of multiple complex regimes, there is a failure. Now, there is a fear of weight gain. One thing about insulin, that you have a sarcopenia due to uncontrolled diabetes, it is reversed and you gain weight, is a good weight in muscles. Your bad weight is abdominal fat, which is a white fat. Good fat is a brown fat, which has got mitochondria. So you gain weight in a positive manner, which is helpful. Poor or infrequent communication with the patient. You don't have time to talk to the patient on the telephone. Can you imagine? I answer about 300 calls every day, or various dosage regimes, and I patiently take all the calls. Many doctors even don't pick up the phone because you're the only connecting link between this modern medicine and the patient. Poor chap, he wants to know. Even if you write it down properly, explain to him, and so-called nurse educator and diet educator, they only make the matters worse. Poor or infrequent communication is a major hurdle for hospitalization. Now there is a cost. You can't avoid cost. But I have calculated that the cost involved in managing good diabetes control is much lesser than if a person has to get admitted and has to undergo dialysis. End-stage renal disease, a person can spend as much as 30,000 rupees a month. While just to prevent proper hypertension management, diabetes management, you need around 150 to 200 rupees per month, plus the cost of insulin. Perceived lack of efficacy. A lot of people say ये effective नहीं करता है, ये injection नहीं चलता है, बकवास है, ये duplicate है. There is a lot of problems in keeping the cold chain, and that is very important. If the insulin is taken out and kept outside the fridge, not between the 2 degrees and 8 degrees, then it is kept in a glow compartment of a car or kept in the coat and you're traveling all over, obviously the potency will go down. So you observe the discipline that you have to keep about how to store and how to give injections. Next slide, please. Being empathetic and supportive, you have to sound not like a teacher, but as a friend. Sakhya, you should be his friend and he should have faith. Once the patient develops faith in him, you can give him any tablet and he'll feel nice. It is the faith, and the faith is only pursued, faith is only obtained if you have the feeling that this man cares for me and all the emergency he will stand by me like a rock. If they develop this faith, then they are very open to take any treatment from you. Next slide, please. Initiate sequential counseling. Don't teach everything on one day. Thoda, small doses. Call him second day, third day, and don't charge all the time. Follow-up fees you should be reduced. Next slide, please. Use easy to understand analogs. Don't give complicated examples. Give simple examples. Give the biokinetic PKPD of the insulin. What is the time action profile? What is the peak action? In a simple manner. Don't give them molecular biology. It doesn't work. Next slide, please. Avoiding one size fits all. It's highly individualized therapy. You cannot give a same treatment to other patients. There are so many factors which decide the dosage, the weight of the patient, the age of the patient, the diet of the patient, his cultural characteristics, his culture, food, eating habits, and his relief in so many religious things. Religion in India is a major issue because in India, after 365 days, there are 265 days of festivals. And that way we are completely neither me. I celebrate Eid also, I celebrate Ganpati also, I celebrate Christmas also. And all celebrations are associated with sweet and highly fat food. So you have to really understand the patient's food culture, his eating habits, and what is the rest of the family eats. Because your diet should not be totally different from the rest of the family. The fellow should not feel that he is outcast. He is not belonging to his family. Everybody is eating amba on the table, amras puri, and this man is just eating pav bhaji, which is also a dish in India, but eating sukha roti, and rest of the people are having a ball. So this should be avoided. Next slide, please. Demonstrate the ease of insulin initiation. Show the injection, how to take. Next slide. Apply the teach back. Ask the patient, मैंने क्या सिखाया, from his experience and from his words and his language, depending on the literacy. Because in Bombay, we are familiar with 4 languages, I tell you. Hindi, English, Marathi, and Gujarati. All these 4 languages, we are very well. And if you talk a language of the patient, he feels confident. Matrubhasha is the most important language of communication. Next slide, please. Provide information in multiple spoken, written, and pamphlets. Next slide. Simpler titration algorithms and self-management programs. Next slide. Now, science of diabetes. Now, this is another big headache. Every day we find there is some cause found out. We had ominous octave, 8 Shatru, 8 Shatru. Now somebody came with dirty dozen, 12. And the 13th one, somebody said even brain is involved. Luckily, people think that brain is involved somewhere. So you see now this ominous octave. Next slide, please. You see what happens, development of type 2 diabetes is progressive. Normal regulation of glucose metabolism is determined by feedback loop involving islet cell, beta cell, insulin sensitive tissue. There is an insulin resistance. By and large, genetically, Indians are insulin resistant people. And one of the example is polycystic ovarian disease in a childhood of a 8 or 9 year old girl. She has delayed, a 14-year-old girl has a delayed menses or severe dysmenorrhea. She has a high insulin resistance. First is insulin resistance, then the progressive beta cell failure, decline of insulin therapy, insulin secretion. First, the insulin secretion is augmented. There is a state of hyperinsulinemia, which is a bigger dangerous factor because hyperinsulinemia invites hypertension. Both are great enemies. Postprandial blood glucose level starts to rise. Then the fasting blood glucose rises when all the beta cells are exhausted and there is a chemical diabetes. So progressive beta cell failure determines the rate of disease progression. And in some patients, genetically, beta cell apoptosis is enhanced. Programmed cell death is known as apoptosis. That is what the God has trained each cell to die at a particular time. Otherwise, all of us will become Amar. It will not happen because every cell is supposed to die after a certain number of years. So, but this program apoptosis is enhanced in type 2 diabetes. Next slide, please. Now, this is science. So, you'll realize that various parameters impact type 2 diabetic pathophysiology is so-called as ominous octet, increased hepatic glucose production, increased glucagon secretion by islet cells, decreased glucose uptake, increased lipolysis, impaired glucose appetite regulation, decreased insulin secretion, increased glucose reabsorption by kidney, and decreased incretin level all produce hyperglycemia. So these are the so many factors which cause hyperglycemia. Next slide, please. So diet and exercise is the first line of treatment we give, which normally fails. Then single drug monotherapy. Then few years we give up titration of that dose. Then we give combination. Now there are 8 or 10 drugs available. And I see so many prescriptions. The patient is taking 8 or 9 drugs, but he has not been put on insulin. I don't know why doctors do that. OAD and basal insulin, OAD and multiple daily injections, and that is what happens when the HbA1 starts going. Over a period of 15 years, this is what the decline of the sugar metabolism. Next slide, please. Now, obviously, you can reduce all this by early intervention program, sequential therapy, early combination therapy. Next slide. You be little aggressive. Now, time in the range refers to the time spent in individual's target glucose between 70 and 80, which is very important. Therefore, you have to put a patient on CGMS. And that percentage of time below or above time in range may be used an appropriate endpoint in a clinical research as a measure of glycemic control. And emerging evidence suggests that TIR is inversely correlated of risk of developing microvascular and thickness, intima media thickness of coronary artery disease. Means what? If a diabetes is not under good control and a postprandial blood sugar is high, you are going to come to me in Asian Heart Institute in 5 years. And if you can intervene, you're intervened properly by either angioplasty or bypass, you live for another 8 or 9 years, then cancer is waiting for you. It is very unfortunate that immune inflammatory disorders and oxygen-free radicals are the cause of cancer. Remember one thing, number one cause of death in Mumbai, at least I can tell you, will be cancer after 10 years. And that is completely in the hands of doctors to prevent it by intervening with the dietary fats of omega-3 acid versus omega-6 fatty acid, reduce oxidative stress, avoidance of smoking, and worst thing is sedentary habits. They say if you sit in a chair, like all of us doctors, we sit in a chair for 6 hours, it is equivalent to smoking 20 cigarettes. So be active. When you want to use mobile, get up from your chair and walk while you talk. Don't use the elevator, use the staircase. Don't use a vehicle for a short distance. And don't tell your work to do anybody else. If you have people in COVID lost 20 kilos of weight because there were no maid servants. Even if you iron your own clothes, for 30 minutes, it is equivalent to 30 minutes of walk. So did that be your real scientific input put in the art of medicine? Next slide, please. Now, obviously, TIR and microvascular retinopathy and microalbumin are affecting kidney. Next slide. TIR and coronary intima media thickness directly proportion. 10% increase TIR with 6.4 lower risk of complication. Next play. Challenges in Indian scenario multiple. We have just got too many food dishes. Modi ji says Vasudevakam Kutumbakam. Vasudev, Vasudha, that our universe is one single family. And if that is true, then India will be the kitchen of that family. That is the diversity of food. And variety of food that is available is amazing. Every 15 kilometers, the taste of the curries, every 15 minutes, there are different sweet dishes. Even in Kokanpatti, in Maharashtra, there are about 300 varieties of food. So this is a major problem in India. Next slide, please. So what is the South Asians as a phenotype? Increased type 2 diabetes susceptibility. First is evolutionary determined poor beta cell function, low lean mass, impaired insulin secretion, response to lifestyle, ectopic fat deposition in liver and muscle, impaired insulin action. Now, hepatic overload of fat is another big cause of death in our country. Next slide, please. So, now high carbohydrate is a common Indian reality. I don't have to talk much about it. Next slide, please. And you'll realize that our most of the time when we are awake is spent in postprandial state. We have breakfast, lunch, and dinner, three major meals, and in between we have mid-meal snacks. So by and large, Indians eat about 6 times a day. So most of the time is in a PP state, which has to be controlled. Next slide, please. And there is a short-acting insulins, which are ultra short, very useful, which can be given after the meals, and they have a big tool for that's a scientific development. Next slide, please. So recent evidence, reduced glucose excursion, improved time in range. This in surging insulin and sugar, glycemic variability is a bigger risk factor. Morning blood sugar 60, afternoon blood sugar 200, night blood sugar midnight 20. Yeah, because night dose of adjusted according to fasting sugar. That's the time when the midnight hypoglycemia takes place. And the counter-regulated hormone push up the sugar in the morning and you see a fasting sugar 200. So this glycemic variability is a bigger risk factor that has to be controlled. Next slide, please. So friends, I tried to cover a subject which is very dear to my heart because that is what I practice. And I wish I have stood up to Shashank's description about me at least by 10%. Thank you.
Thank you so much, sir. Thank you so much. You want to take question and answers, Bansi, now, or should we take it after the second talk?
No, we can have the question here and then again after Ajat.
Yes. I can answer any question just now, no problem.
Okay. Anyone has any questions or comments? Manika, if you would like to comment on behalf of Anya, maybe we'll take a comment from Manika and Bansi, and then we'll probably open it up.
Yes.
I don't see any questions in the question box.
Normally, Shashank, after such a lucid lecture, there are never questions asked to me.
Okay. I think that was self-explanatory. That's what I was going to say. The science was cutting edge. I mean, I really enjoyed that. Time in range, all the latest things were mentioned. And unfortunately, in our part of the world, still, we don't have the CGMS. So we are hoping, at least our IDF president also said he's pushing in future for very low cost CGMS, which we don't have at the moment. So we don't have that, data to manage our patients. And what all about the insulin is spot on. That's what happens. But unfortunately, now busy practice, including me now at 9 o'clock, I have 20 more patients sitting outside. We can't spend 45 minutes. That should be the case. but it takes about 2 visits in Sri Lanka, 2 to 3 visits to convince them on what you said. And we try to do that. And I picked up, a few clinical pearls. Thank you very much. And it was really
Thank you.
interesting. And I think the art of medicine was a learning thing for all of us, and with the latest thing. So thank you very much, Dr.
I will just
Bhaskar.
end my lecture by telling you that what I try to give you is wisdom. And the difference between knowledge and wisdom. What you learn in the school textbook of medicine by CMEs is the knowledge. And what you have over a period of 40 years by seeing thousands of patients and you take a diary, "Ki this patient taught me this," that is a wisdom. So in
Yeah.
simple language, to know that tomato is a fruit is a knowledge. But not to put it in fruit salad is a wisdom.
Well said.
So what a lucid
Thank you very
talk
much.
you had
These are
given.
called
We all
Boraskar's Pearls of
enjoyed.
Wisdom, which we are
Yes,
compiling in a book.
pearls
I'm
of
promoting
wisdoms
his
are
book
there.
here. That I would like after.
Shashank, many doctors have commented, not in
Huh?
this chat box, and then I just asked that what is this title. They all liked and enjoyed the topic. And there was one comment that, sir, again, to teach or educate the patient, that art of medicine, again, reason specific also. So, I mean, the same, what you are practicing maybe in Mumbai may not be all the time to someone who is practicing in a rural area, maybe Northeast area, maybe in Sri Lanka, maybe in Bangladesh, but still the pearls of wisdom which you had given was very, very important, which we don't learn in medical school, which we learn from someone like legends who is practiced since last 40 years. And every day what you have seen in your last 40 years, you are now teaching in 40 minutes. So we all enjoyed your talk, sir. Really.
Thank you very much.
Thank you.
Thank you, sir. Thank you so much, sir.
Shashank, now please introduce Dr. Ajad Khan, sir.
So Professor Azad Khan, sir, is the living legend from Bangladesh. He founded the BIDRM. He has been the immediate past chair of the IDF Southeast Asia region. He's an honorary member of the IDF. He's the one who, from Bangladesh, went ahead and did this whole movement of using the Friday time of prayers to cause diabetes education, and is very committed to the cause of it. He was able to tell the Bangladesh president to become a spokesperson for diabetes for people living with diabetes. His commitment to diabetes is unique, unparalleled, and he's also not just a Bengali scholar, but he's also a Sanskrit scholar. He's always taught us pearls of wisdom, and just like Professor Boraskar, he's simply outstanding, a very humble human being, and always helpful for people from the region, but across the world. And his protege, Professor Akhtar Hussain, unfortunately we lost him, was the president of IDF. He always promotes the next generation. And we are very grateful to you, sir, that you are going to give your pearls of wisdom in your current talk. And he has pioneered not just the Southeast Asia guidelines, but also the global guidelines. And I would request Professor Azad Khan, sir, now to take over.
Well, thanks for your generous comments. I just want to congratulate Anil, because I think you have given a very excellent talk. I really enjoyed it, you see, and a lot of wisdom. I always say a successful physician is the one who delivers science in the form of an art. And this combination is very important. Second comment I want to make, I'm seeing Bonsi and Shashank after a long time. It seems that both of you have become even younger. Bonsi, you have lost, I'm sure you have lost a little bit of weight and you have become younger. But anyhow, coming to my topic, I shall hurriedly go through the topic, what we do in Bangladesh, then leave it for question, you see. First slide. So I'm talking on the primary prevention of diabetes, as you know, and in the context of developing countries, lower and middle income countries. And diabetes has been recognized as an epidemic, but it was recognized as an epidemic even by United Nations. So that's why we have got a UN Day for diabetes. And I dare say that I played some part in it, you see, because it started with my letter to the government of Bangladesh. What I really want to point out that this UN resolution is not a simple piece of paper, you see. It is, you can see that if the Secretary General of the United Nations invited all member states and relevant organizations to take up prevention programs. See. So we have to think ourselves how many of our countries have taken an official prevention program. And the pandemic is mainly due to type 2 diabetes, as you know. And these are the figures, I will not go through it. But the major barriers in organizing diabetes care in Bangladesh, for that matter, in all developing countries, lack of adequately trained person, especially in remote areas, you see. And also professional attitude, as Anil was showing, that the doctors don't have time or they are not so patient friendly, like this, you see. And in this context, Diabetic Association of Bangladesh has organized a system of care spread all over the country by the model. And it's a huge organization, you know, that we have not only care, we give care ourselves. You see, usually, diabetic associations in other countries are advocacy bodies. But in Bangladesh, our founding fathers took the view that if we want to really give care where people are not even oriented for non-communicable disease, that we provide care ourselves. So we have got many hospitals and also system of creating manpower. So you've got quite a few medical colleges and University of Health Sciences, nursing college, etc., etc. So it's quite a huge structure, you see. And then we have got non-conventional method of creating manpower, like certificate course on diabetology. We have started this nationwide diabetic registry that should be completed in a few years. And now the guiding principle of the diabetic association is that we provide comprehensive care, and we have made the community participation and decentralization is only Dhaka based, you see. And also emphasis on qualified trained manpower. And there is also, so that we can attract good manpower, so there is priority to academic and research initiative and democratic management policy, because all our organizations are run by elected people. And there is public-private partnership and self-reliant financial management. We are assisted by the government, but we are basically uh, self-reliant. So our model is that we cross-finance, you know, we charge richer people and subsidize the poorer people. And also, all our institutions are there's general health care, including cardiac care, neuroscience, plastic surgery, is a complete general care. So that helps us to what we call co-finance poor diabetics by selling the services to non-diabetic. And diabetes prevention is one of our core program, and we adopted this even before UN adopted it. And this is our largest institute in Bardem. Is known. It used to be a WHO collaborative center. In fact, Bardem was the second WHO collaborative center in the world on diabetes. First was Borak in Zagreb. See. And also, we have got a big rehabilitation program because we try to give comprehensive care to diabetes and also train them in different vocations so that they can become an earning member and support themselves, you see. And now one of our big programs is distance learning program, because I think the diabetes care will ultimately become digital, you see. So the emphasis is now that here I can see Amit here. So he's going to appreciate this. And diabetic educators, one of the shortcomings in developing countries that we don't give the importance to diabetic educators. You see. So we have made it compulsory that to be accredited with diabetic association, they must have the position of diabetic educators. But diabetic educators are not available. So we created about 100. Now we are creating all the time, you see. Mm. And we have got apps, the BADAS guideline, you see. As I said, the diabetic registry. And manpower development, I said that this. And our distance learning program, you see, on certificate course of diabetology is well appreciated by many organizations. And then where we don't have an association, we have created what you call accredited physicians studies. Because so now we have got in every thana at least one accredited physician for diabetes care. His chamber, the doctor's chamber, is converted to a primary diabetic care unit. And they are also connected by telemedicine, the main centers. We have got several vans. The main van is this, you can see. So it can give care by mobile care. Diabetic Association has also taken program, what we call universal health care, you see, by using microcredit. You see. So as I said, digital care. So we are now in the process of setting up many digital care centers. You see, it's not only for diabetes as a whole, but there's an emphasis on diabetes. You see, and I will just show you what it looks like. Comprehensive digital care. These are the areas where we have already piloted it. You can see basically it needs about 2,500 square feet of place where you can also do outdoor intervention, you see, so that people don't have to be hospitalized. I've noticed that Anil said that if a person has to be hospitalized, it increases cost. So here also the daycare. So this, and in the daycare, in this program, we are training a group of physician assistants, you see, so that the people, the experts seeing patient online are assisted at the patient end. And their training program, I will go through quickly. And as I said, our main theme is primary prevention. So here in primary prevention, I want to emphasize one thing. The medical community as a whole, throughout the world, is far behind, let's say, of business community. You see, if you think of the business community, then how they promote fast food and they get people addicted to fast food, and we are no match to them, you see. So we have to think of finding ways what will really motivate people. Or in other words, we have to find the language what will motivate people. Here I'll give an example of, although all the factors of prevention are not known, lifestyle modification is effective, that we know. And there are many studies have been done. I'll go through it. Even drugs. We have conducted a study where we have used also a small dose of glyphosate, and that also gives some prevention is found. And we have proposed to the government for a national policy of prevention. And in that policy, you can see that we have even proposed that to prevent malnutrition of pregnant mother is also very important. And also to create awareness. So different awards are given. And in that awards, that what contribution they have made for prevention of diabetes will be considered. So just a little point. No. As I said, using the right language and right medium for provocation. I'm bringing an example, you see. Who doesn't know smoking is harmful? Everybody knows. but also some of my audience, surely many of them have taken a puff in their life. So the first puff is very unpleasant. So a substance which is so harmful and is also very difficult to start with. But cigarette companies are able to recruit people, you see, people. And you can see the method they have taken, you see, taken. You can see vegan smoking. And on the bottom line, you can see the most popular Bengali hero ever born, Uttam Kumar smoking. You can see the other person. So these are the methods they have taken. And so we thought that we try to find out right language. So one area that we have used, using the religious leaders, because religious leaders have got great influence in our population. So we have used the religious leader. The first one is pre-conception care. We did that people starts this after pregnancy. So we thought, why not start at the time of marriage? And we give the message through the marriage register, and we found that it has quite a big effect. I'll go through it, and it reduces. These are the training of the marriage registers. You see, marriage registers called qazis in this part of the world. Uh, and we started pre-conception care centers. You see, where people can go and this. The basic message is, at the time of marriage, the qazi says that God has given us enough knowledge where we can plan pregnancy. So when he advises the couple, when you contemplate pregnancy, get the lady checked for weight, hemoglobin, blood sugar, blood pressure, like this. You see, 6 things. And you can go to preconception care desk, and there you can do it at very minimal cost. And we found that uh, that these are the different steps. And this pre-conception care, we make a little chart, you see, that gives value to it. And this 1, 2, 3, these are this. And surveys that we showed that this knowledge that we had. I'll just come to the last slide on this. So prevalence of GDM has gone down. People who have followed this is now under preparation for publication. And we have been able to persuade the government that now the marriage contract will bear a seal that pre-conception advice has been given. So this is just, and that we have been able to achieve that. So this project has been selected for UN high-level meetings. And that the booklet consensus guideline, this. And you can see the GDM intervention area is 17.4, and in the control area it remains 35.6. Big difference, you see, and a very low cost. Second project we did is using religious leaders like mosque imams, you see, and the church leaders, you see, bishops and archbishops, and also the Ramakrishna Mission, so that they give message, this. And in Muslim religion, they go to Friday prayer every day, and there the Imam gives a sermon, which is called khutbah. So in khutbah, we are able to incorporate this message, you see. And that was given, and we found that this training program, and the sermon that we made was authenticated by the Al-Azhar University, whose fatwa is taken as somewhat official, and also by the Grand Mufti of Kaaba, so that it creates really faith, you see, in people. And we have circulated in all the OIC countries. We are also able to start a diabetes corner in every mosque. As you understand, the mosques are occupied mostly on Fridays. The rest of the day it is mostly empty. So we have started diabetes corner, and we have trained the mosque imam in diagnosing and giving primary advice. We have provided them with a tab, and they are connected to the center. See, so it is also a self-sustaining project. This. So these are the places. Even we have tried this even in the Buddhist temple. The full paper has been submitted for publication. I shall not go through the detail, baseline, etc. This, and we have done the impact study, and we found that very low cost it has produced a big effect on the prevention. You see. I shall not go through detail. These are the details of the paper. You will have it. So this is message is prevention of diabetes is feasible. That we have to find the right language and the right medium. You see. So that's the summary. We have done other studies like participatory learning cycle, where people get together and they solve their own problem. You see, and adopt it. And this has also been published, and we found quite a good effect by that. You see, we also tried mobile messaging. You see, still today the messaging that we have done, we have found that it has created more awareness, but it has not made any practical effect. So maybe that we have to give more message. So or may have to modify the message. So that's my final message. Prevention of diabetes is feasible, but we have to use the right language, the right medium, and every country has to find out what is the right language, right medium. In fact, I presented this in, I think 2 years back in Lund University. And then there, they said that our people have no faith in religion, you see. So what do we do? I said that your people have faith on something, maybe a sportsman. So use them. You see, you have to find out a medium on which people have faith. So that's all. Thank you very much. If anybody has any question.
Thank you so much, sir. I think right language, right message from the right person, making diabetes prevention feasible and possible. I think that is your summary.
That is my
And you are very realistic, because you have given us a realistic perspective of a topic which is very difficult. Because this is a one topic which is very easy to say on theory, very difficult to practice. And you have gone from individual level to family level to community level to national level to global level. So I think that is you have encompassed each, given real life examples of your vision, your mission, and how you have implemented your vision and mission into actual reality in your own country, and then how it has been adopted by IDF across the globe. So I think I must congratulate you for this, and I think this is a very well put. I'm sure there will be questions. First, I'll request Manika, who's representing Dhanya, to maybe also give a couple of pearls of wisdom. I'm sure Dr. Boraskar Bansi is here. They might definitely like to ask a few things. I can see Dina also, if she would like to make a comment or two, and Biswajit. Biswajit has been working with Sir and now is spearheading the DASG group as a secretary and a very active member of Bangladesh Diabetes Association. So maybe they can all have comments. Noj is a little busy, I think, right now. But Manika, you can start.
Yes. Thank you very much, Professor Asad Khan. Really enjoyed your lecture, although we have heard bits and pieces about Burdom and what you have done and how about the Diabetes Association. Only today I actually saw the scale of things. And congratulations. I think it was tremendous, from primordial prevention to tertiary care and training doctors to health workers and imams and everybody. So you have sort of captured the whole very comprehensive approach from prevention to treatment of diabetes. But out of all that, what I stuck my mind with, we also try lots of prevention programs, all that. But you have shown with the numbers that reduction, halving the incidence of GDM, I think is one of the greatest achievements, because as you know, the seeds are sown at that level, and our younger generation is getting diabetes earlier and earlier. So I think that is a huge achievement for any country with such a high level of GDM. By these measures that you have taken, that you have actually shown tremendous results, and I'm sure in other areas also the results will be seen in future. So thank you very much. We learned a lot, and I think bits and pieces, whatever we can do, we can adapt from this model in our country, which is, I think, applicable and very practical for our region. Thank you very much.
Thank
Professor
you.
Boraskar and Bansi.
Yeah, I would say only one thing. The GDM is one thing which is considered as a pre-diabetes. And basically, the GDM is a major enemy. You know why? Because in our country, in order to get mother to get a proper lactation after she delivers a baby, the grandmother, the mother, the sisters-in-law, and all that, they bring such kind of food which such as dinka ladu, alibuka ladu, gudka ladu. They want the mother to develop good amount of milk, because there is nothing like mother's milk, because mother's milk contain omega-3 fatty acid. One lady who has never touched a fish in her life. So this is what God has created, mother's milk. But in order her to get almost 1.5 to 2 liters of milk is fed to her during gestation period as well as postpartum. Now problem is, I have seen this diet makes her put on weight, and then she has a difficulty in knocking off that weight. And I have seen some unfortunate husbands also, in order to eat the same food, even the husbands gain weight. So this kind of eating practice has to be rationalized, controlled, and a proper dietary counseling has to be done to the mother with the gestational diabetes, or any mother. Her hemoglobin should be controlled, her iron should be restored to normal, vitamin D has to be given. And if you follow that, then the future diabetics in this country can be reduced. This is what I feel. Thank you very much.
And thank you. About mother's milk, Anil, I would like to add a point. It is also not only safe, it is even the cats cannot steal it.
I know. Yeah, that's true.
So wonderful presentation by both our legends. We all enjoyed. And I think if we don't have any other comments, I will request Manilka for proposing vote of thanks. And once again, I am reminding you, and I will be sharing the link for ninth evening meeting, and I will send the proposed agenda also, what we are planning and what I want to listen from all of you, and how we can go for next 6 weeks to 12 weeks. With this, I request Manilka again, and thanking Shashank, Boraskar sir, and all my colleagues who could join. And big thanks to Dr. Ajad Khan, Bishwajit, Deena, and everyone who could spare their valuable time. Over to Manilka for vote of thanks.
Thank you very much, Bansi. It's my pleasure to propose the vote of thanks in this important meeting where all of us enjoyed, and thousands of doctors also would have benefited, mainly in India and other countries. So I would like to thank Dr. Anil Baraska, who has been a living legend. He is a living legend in your country, and I learned a lot of things about him today as well. And for his very elaborate art and science of medicine, and especially diabetes lecture, which all of us would have gained a lot of clinical pearls from that way. So thank you very much, Dr. Baraska, for that wonderful lecture, which all of us enjoyed. And Professor Asad Khan, as always, has given us a very practical and approach from prevention to tertiary care of diabetes. a model that can be adopted in any country, especially in this part of the world, in a resource-poor setting. And I think that was a very informative and eye-opening lecture. Thank you very much, Professor Asad Khan, for taking your time and giving us this wisdom today. And of course, Professor Shashank Byoshi for being my co-chair today and doing the honors and joining us at this time. And all the others, I saw Dina and Biswajit and even others who joined in the section, and the 1,000-odd doctors who joined mainly from India and all over Southeast Asia and other countries. Thank you very much for all of you for joining us for this IDF meeting. And I invite you all to be engaged with the International Diabetes Federation Southeast Asia region meetings, which we hope to do in future as well. And maybe give us your requirements and plans as well, so that we could adapt our meetings in future. So thank you very much, everybody, for joining. And of course, last not but least, our versatile chair, Dr. Banshi Sabu, for taking all the trouble and the initiative and encouraging all of us and organizing these meetings in a very effective manner, and doing all the organizing and getting all the people together and doing all the work. So thank you very much, Banshi, again for the good work that you are doing, and we will be all behind you to help and keep on doing the good work. So for today, I will again hand over to Banshi to give the final words and conclude the session. Thank you very much, everybody, for joining the IDF Southeast Asia meeting today.
Manoj, you want to tell something?
No, I just said that, I may have heard some
Sorry,
of these
Manoj, I didn't see
conversations
that
earlier,
here. Yeah.
but absolutely a delight again to listen to both the legends. Truly a legendary evening with those two conversations where the legends have been able to share their experience, which doesn't always come from the textbook. So their experience and wisdom shared is invaluable to all of us who've been able to attend. So thank you so much for that. And absolutely wonderful that this is happening under the IDF Southeast Asia auspices, and hopefully all of you in the current positions will continue to host many such programs and make us enjoy such an academic evening. Thank you so much once again.
Thank you. So now final word is that we are closing this program and would like to request all of you, those who are from different countries, organization, as a head, as a president, secretary or secretary-elect or president-elect, to join on 9th evening. This will be a sort of a board meeting, so it's not for everyone because the program is already closed on 9th evening, and we will be also discussing that what we have, getting the information from head office and what we are planning to do. So I'll be sharing a rough agenda on Sunday, and on Monday evening we will be meeting. Thank you. Good night.
Good night.